Temple, Texas. And my research, I did this over maternity leave. So I had to come up with a project to do in my 6 weeks off because having a baby and taking care of that wasn't enough. So in order to stay on track and to graduate, I had to come up with a research project. So this is what me and my mentor, Dr. Clay Gowan, developed. So we wanted to look at patients at our institution and how they did with neoadjuvant therapy versus definitive. And we looked at specifically at stage 3, those who had N2 disease that are non-small cell lung cancer. So as we know, the current recommendation is for definitive chemoradiation in these patients that have N2 disease. There are some exceptions that have very small N2 disease that they will take them to surgery, but in general, it's recommended to just do definitive therapy. But as we've seen with survival curves throughout this conference, these patients tend to overall still have very poor overall survival. So we wanted to see if there was anything that could potentially improve that survival. There have been studies done at other institutions that have looked at neoadjuvant therapy. These studies have overall shown a progression-free survival benefit, but there's been a variation in the overall survival benefit seen in these other studies. So we wanted to take a look at our institution and see if there was a difference in our patient population. So we did a retrospective review of patients in our institution. These patients came from our tumor registry, and we were able to have 65 patients that have been treated with definitive chemoradiation therapy over the past 5 years. Now, for those of you who aren't familiar with our institution, we are a fairly large tertiary referral center, so the 65 patients is not a fully representative of how many patients that we've treated. Especially we have a VA that's right across the street, so we do all of the radiation therapy for the VA at our center, and as well as for multiple people around Central Texas. However, once they're done with either their surgery or their definitive therapy, they usually go back to kind of more local communities and finish their treatment there. So we did not have follow-up data on a large percentage of our patients. So the patients that we do have were the 65 patients. We also have 17 patients that have been treated with neoadjuvant therapy. So this varied either from chemotherapy or chemotherapy radiation followed by surgical resection. This was over our data from at least 10 years. We were going to narrow it down to the same 5-year interval. However, we didn't have that many patients. So the 17 is still a fairly low number. We gathered general information on age, sex, their histology, and then we determined their time to progression and time to death. And then using log rank testing, we determined their overall survival and progression-free survival. And we did do a subset analysis based on histology to determine if histology varied on their overall survival as well. We wanted to do additional subset analysis, especially on our surgical patients. However, because of the small population, we were not able to do that. We wanted to look to see if no negative status at the end had any benefit. However, again, we were not able to do that with the small population. So this is our patient comparison. As you can see, overall, fairly similar data between the patients who received surgery versus definitive therapy. Surgical patients were a little bit younger, and we did see that there was a higher percentage of adenocarcinoma that did undergo surgical resection rather than the squamous cell. So this is our progression-free survival results. As you can see that there is a statistical significance difference in our progression-free survival. So those who received any form of neoadjuvant therapy that progressed onto surgical resection had a progression-free survival average of 47 months. This was versus 13 months in those who had definitive chemotherapy and radiation. With a p-value of 0.046. There was no difference based on histology. Our overall survival results also showed a statistical significant difference, however, not as impressive. So 27 months in the neoadjuvant versus 26 months who had definitive therapy. Again, a p-value of 0.04, and there was, again, no difference based on histology. So in our institution, we do see a statistical improvement in progression-free survival and overall survival in those who did undergo neoadjuvant therapy followed by surgical resection versus those who had definitive chemotherapy and radiation. There was no difference based on histology versus any of these treatments. Again, since we had such a limited number of patients who did undergo surgical resection, further evaluation cannot be determined as far as if having negative nodes and that sort of stuff. We did have about a 50-50% split on those that after surgical resection did have negative node status versus still had positive nodes. And so seeing that there's still 50% of patients that have positive nodes and we still see this improvement is encouraging. However, we know that there's a lot of other factors that could go into this. We did not have a definitive look at additional comorbidities and that sort of stuff. So there's a lot of other confounding factors that we realize could affect this data. However, it at least gives us some encouragement to kind of look into maybe pursuing a neoadjuvant approach on more of our patients. And so we're presenting this to our surgeons and our oncologists to at least give them something to consider. And then hopefully we can continue to pursue our data in the future.
John?
So very good. So are you really looking then to take this data kind of forward to pursue more neoadjuvant, or are you going to then look for potentially studies? As we heard earlier, it'd be nice to have more neoadjuvant studies for proof of concepts with some of these newer therapies. How do you really kind of see from your institution, you guys' ideas to take this information and kind of go to the next step?
I think with our institution, I mean, we do some clinical trials and that sort of stuff, but we are very much practice-based practice. So I think that this is just kind of more, we will take this more of an education approach. We recently had a complete turnover in our cardiothoracic surgery department as well. So we're hoping that with kind of the new staff as well, that we'll be able to kind of collaborate with them more to develop a way that we can hopefully better treat our patients.
Excellent. One important issue is the number of nodes involved at the time of diagnosis, how many stations were involved, and that may make a difference in what sort of treatment strategy decided. So that might be worth looking
Right,
at
and
as
we did
well.
not evaluate that, so we just purely went on based on whether or not they had proven into disease at the time of diagnosis. And so that would be another subset analysis that would be interesting to take into account of how many nodes and if they were bulky, et cetera, which it can be an extension on this study for sure.
Thank you.